My name is Dr. Andrew. I'm the director of the Bariatric Weight Loss Clinic, the newly developed clinic here at Sacred Heart, which is a partnership between Sacred Heart and Evergreen Surgical. I appreciate the invitation to speak with you today. And I just want to get a sense of who we have here by a show of hands. Are these all critical care nurses here today? Okay, great. Well, this presentation has some critical thinking that incorporates bariatric surgery, but it also applies in general to every other surgical patient. I'm going to do a little bit of a background on bariatric surgery and the indications as well, just to bring anyone up to speed who hasn't had experience with that, and just a little bit of talk about the nursing care of bariatric patients, in case any of them end up in the ICU, which can happen for patients who are a ways out from their bariatric surgery. All right, so let's get started. Again, thank you everyone for joining us tonight. So what we're going to talk about, as I said briefly, the obesity epidemic, the type of surgeries we perform, postoperative nursing care, signs of postoperative complications, and then really interesting at the end should be some case scenarios where I hope it's a very interactive session. Now, many of you have probably seen this diagram. The prevalence of obesity has been increasing significantly in America over the last several decades. In the 1980s, there was not one state that had greater than 20% obesity. Now every state has greater than 20% obesity. Wisconsin has greater than 30% obesity. BMI, you all know this is characterized based on a metric weight divided by height squared. Normal is 18 to 25, obese 30, morbidly obese start to 40. And also, this is important now, and it's going to be more important in the future as well. Adolescents and children have a high rate of obesity as well. This is not a problem that's only limited to adults nowadays. I'm not going to go through every point of data here, but I'll just tell you that obesity is very costly, as you all can probably imagine, even without the precise numbers. There are conditions related to obesity, such as diabetes, high blood pressure, sleep apnea, and obesity can complicate medical care. For obese patients, they have double the risk of high blood pressure, 3 times the risk of diabetes. They have more visits to the hospital. They have a higher rate of wound infections after hip and knee replacement. And in fact, some orthopedic surgeons won't do this procedure in obese or morbidly obese patients. They have a high risk of stroke after vascular procedures. And we all know it's more difficult getting them up from bed, moving them around, getting imaging, getting IVs placed in those morbidly obese patients. Morbid obesity can be considered the leading cause of death in the United States. It has surpassed smoking as the leading cause of death if you count the comorbidities that are related to obesity causing the death. A 25-year-old male who's morbidly obese has lost 12 years of his life from obesity. Multifactorial causes of obesity include vectors, hosts, and environments. Just very briefly, energy density of our foods can be considered a vector of leading to obesity. One example is that in the 1950s, a movie popcorn was 3 cups. Now it's 21 cups. A Hershey's bar used to be 2 ounces. Now it's 7 ounces. And we eat much more high fructose corn syrup and less natural cane and beet sugar. Physical activity is declining. We all know this. We all have increased sedentary activities like going to movies, using the computer, social media, things like that, passive modes of transportation compared to before. The recommended physical activity level is 150 minutes per week, which is 30 minutes a day, 5 days a week. Many people don't get that level of physical activity. The environment is another factor. We have something called food deserts, which are areas where, because of lack of transportation or no access to grocery stores, individuals can't get fresh fruit or vegetables, and they end up eating fast food and junk food that's not good for them. Wisconsin, in fact, has 3 times the number of bars compared to grocery stores. This also contributes to poor eating. Genetics plays a big part. That's not surprising, I'm sure. You've all seen obese patients who have obese family members as well. If both parents are obese, children can be almost 12 times more likely to be obese compared to children who don't have obese parents. So here at Sacred Heart, we're creating a journey to help patients through their weight loss goals and help them achieve a healthier and happier life at a healthy weight and with improvement of their comorbidities. We have an educational session. We have scheduled appointments with dietitians, psychologists, exercise therapists. We have final visits with primary care physicians, pharmacists, and then a pretty comprehensive follow-up schedule as well. Now, surgery for morbid obesity has been proven to be effective long-term for resolution of obesity as well as comorbidities that we talked about earlier. This is echoed by the National Institute of Health, American Medical Association, as well as the American Association of Family Practitioners as well. The requirements for bariatric surgery, they vary significantly by each insurance provider. In general, you have to have a BMI that's greater than 40, which is usually 80 to 100 pounds overweight, or a BMI greater than 35 with comorbidities. But as I said, it can get very complex, especially dealing with Medicare or Medicaid, who have more criteria than just this. Patients who have obesity caused by metabolic conditions or who are at high risk for surgery because they're non-ambulatory, have some other significant high cardiovascular or respiratory risk factor or an active malignancy that needs to be dealt with first, are not eligible, but we still work with these patients and help them through medical weight loss. Now, the types of surgeries that I do, the gastric bypass and the gastric sleeve, they can both help you get around 60-80% excess weight loss. And to clarify what excess weight loss means, if your BMI is 25, which is normal, you'd be in this middle of this green section. Your excess weight is anything above that. So someone who's 5'10 and 330 pounds has a BMI of 47. They'd be right here on the diagram. If they lost 70% of their excess weight, which is what's expected, after either of these surgeries, you could get down to about 225 pounds. It's important to note that this is not a normal BMI. You're not expected to get back to normal BMI, although I have had some patients who have lost 100% of their excess body weight. But I feel comfortable telling people 70% is the expected amount. However, losing that much weight, going from 330 to 225, is going to make you much healthier, improve your morbidity, mortality, and comorbidities as well. So the gastric bypass is created by making a small pouch and then bringing up a bypassed loop of jejunum, connecting that to the stomach and biliopancreatic secretions about 150 centimeters downstream. The small pouch prevents the patient from eating as much as they would before, and the bypassed area reduces absorption. Complications exist with any surgery. For this surgery, wound infection is a complication, as with any other surgery. Internal hernia, dumping syndrome, marginal ulcers, leak from any of the staple lines or any of the connections, and nutritional deficiencies. The gastric sleeve, visually and technically a little bit simpler. We remove the body of the stomach, about 80% of the stomach, leaving a narrow tube. This allows food to go through faster. It also reduces the amount of food that you can eat at one time. The patients I've had who've had this surgery tell me they don't feel hungry like they did before, which is very reassuring. Again, complications can occur with any surgery. Complications specific to the sleeve include leak, reflux, although that's debatable now, whether it ultimately improves or worsens reflux, and nutritional deficiencies. These are all done laparoscopically, and I won't go through this in quite as much detail as I have on the slide. And then just a few words about postoperative nursing care for these patients when they're on the floor. So similar to any other general surgery, monitoring vitals, including urine output, assessing pain control, facilitating liquid intake, encouraging ambulation, and being aware of change in status. We have a pretty specific diet progression. On the first day, they're given ice chips. The next morning, they can have clear liquids. They get small 1-ounce shot glasses, if you will. They progressively increase the amount of fluids that they take over time. And the goal is to get up to 64 ounces per day, which most people can achieve in the first 2 or 3 days. Some patients will have nausea, especially the gastric sleeve patients, but that can be managed with antiemetics. They are going to get IV fluids running while they're in the hospital, since in the first 24 to 48 hours, they're not going to be getting that full 64 ounces a day. This is more important for the floor patients. These are just some guidelines on urine output to rates and criteria. They'll have cardiac monitoring. They'll have the Foley removed on the first morning if they have a Foley placed. The gastric sleeve patients generally won't need a Foley in place. Pain control, we're doing things a little bit different. Many of the bariatric programs at academic centers are using an ERAS protocol, which the significant part of that is a lidocaine infusion, which we begin at the beginning of surgery and continue through to the first 24 hours after surgery. This has been really helpful in reducing the need for opioid pain medication. However, we will provide some opioid pain medication as well. Ambulation is very important for morbidly obese patients. They'll also get Lovenox either daily or twice a day, depending on their particular characteristics. Some patients will have specialized DVT protocols depending on their history of prior DVTs or PE. CPAP, if any patient who has obstructive sleep apnea must wear their CPAP at night when sleeping, or even if they're just planning on taking a nap. We encourage incentive spirometry just like any other patient, and head of bed elevation as well. They're expected to be in the hospital for about 2 days. They'll leave on the clear liquid diet. They'll have a booklet describing all the different variations and sample diets that they can try. They'll get oral liquid opioid pain medication, as well as a follow-up schedule that will already have appointments set up. Their diet advancement, in case they ask you, the nurses in the hospital won't necessarily be part of this, but in case they ask you, the first couple of weeks are going to be clear liquid diet. Next is going to be full liquid and puree foods. The second and third month, they'll advance to soft diet, gradually returning to a balanced diet consisting of small meals. And of course, fluid intake is going to be very important over this time period as well. So some people think of bariatric surgery as a shortcut. I assure you it's definitely not a shortcut. It's a lifelong process. It's very challenging for some patients, but the rewards are worth it, I think. This means lifelong clinic follow-up. It's less intense as time goes on, ultimately becoming just yearly. And some patients who are doing well often transition to just their primary care physician, obtaining labs, and not even coming to see us after a few years. But in the beginning, it's a 1 week after surgery, 1 month, 3 months, 6 months, and then 12 months. We encourage, and it's important that the patients continue their physical activity, 30 to 60 minutes of moderate and intense activity most days of the week. We have support groups available. We have referrals to plastic surgery for abdominoplasty if a patient is interested in that. Now, of course, we hope there aren't postoperative complications, but it's important to keep a lookout for them. The early complications of bariatric surgery include bleeding, obstruction, leak, or pulmonary embolism. Late complications, some are specific for gastric bypass, include marginal ulcer, internal hernia, incisional hernia, nutrition deficiencies, supramesenteric artery syndrome, and gallstone formation. The keys to identifying these complications: identify and recognize any vitals or labs that are outside the normal range, or a significant change in symptoms or exam findings. If someone suddenly becomes tachycardic, that's a change that should be communicated up the chain. If someone suddenly has an increase in abdominal pain despite constant rate of pain medication, similarly, that should be communicated forward. From there, thinking critically, formulate a differential diagnosis, keeping in mind the type of surgery they had and the special circumstances of the patient. So now let's talk about some scenarios, and we'll focus on the typical signs of each type of complication. These are just the typical signs. Of course, you can have an atypical presentation of a common complication as well. And this should also demonstrate some of the similarities between the different presentations that we can see in these bariatric patients. So, clinical scenario number one, night of postoperative day 0. Let's say this is a patient who had a gastric bypass and they're about 12 hours out from the surgery. Heart rate is 120, and it's been persistent despite a 1 liter fluid bolus. Blood pressure is 98 to 45. Afebrile, SATs are 97%. It was hard to find a picture that had everything that I wanted to talk about in there. Their only complaint is incisional pain. There's no nausea or vomiting, and the hemoglobin that was drawn immediately post-op is 13. So, going through the method I talked about, let's identify what's outside of the normal range, if anyone wants to speak up. This is an easier one, so anyone who wants to say what's abnormal. Tachycardia and the blood pressure, right. And then what is normal in this case? The incisional pain. The hemoglobin 13 can be normal for a patient immediately after surgery, especially if they came in a little dehydrated. Now, this patient had a bypass. Knowing the immediate complications of gastric bypass, what are some of the potential thoughts that we have that could be wrong with this patient? Anyone could speak up. That's absolutely a good thought. Tachycardia and hypotension. Any other thoughts as well? Yeah, absolutely. And many surgical patients come in dehydrated, especially if they've been fasting the night before. So in this particular patient, I wanted to talk about postoperative bleeding. So in this situation, if tachycardic or hypertension, they're going to get a fluid bolus. Hemoglobin likely rechecked if they're stable enough. 9.5 was the recheck in this particular patient. These patients, if they're bleeding to the degree that they are unstable, they're going to need re-exploration one way or another. They may need a transfusion. This depends on the acuity of their situation and how stable they are, how they're responding with fluid resuscitation. But in general, they're going to need re-exploration. Bleeding can happen from any of the staple lines or any of the cut surfaces. This is usually going to be something that will be oversewn to stop the bleeding. So scenario number 2. This is same patient, heart rate's 120, or gastric bypass patient, post-op day 2, heart rate's 120, blood pressure 105 over 55, only complaining of incisional pain, white blood cell count is elevated, temperature is elevated as well. So, we can see heart rates up, maybe signs of infection. What sort of thoughts do we have in the early postoperative period, day 2, for a patient presenting like this? Okay, yep, absolutely, that's a possibility. You have essentially SIRS findings, so infection is a good thought. Any other thoughts? Leak is an excellent thought with a bariatric patient on day 2. They're only complaining about incisional pain. Does that make you think a leak is likely? Well, I'll move forward and say yes, absolutely. So some of these patients, because of their obesity, they have very thick abdominal walls. They may not have the peritoneal signs that you see in other patients who have, for example, appendicitis, cholecystitis, diverticulitis, things like that. The day 2 is about when you're going to see the manifestation of a leak, not just for bariatric patients, but for any anastomosis. For these patients, the leak typically is going to be at the GJ anastomosis. So you can use a upper GI study, a gastrograph, and so extravasation of contrast, pictured here. These patients are going to need initial fluid resuscitation antibiotics, and then they're going to have to return to the operating room for a washout and then drain placement, potentially revision, potentially stent placement. Oftentimes revision is not possible because the tissues are going to be so friable and inflamed that they're just not going to stay together. Okay, good. So scenario 3, day 1, gastric sleeve. So this is the first morning after gastric sleeve. Heart rate's 85, blood pressure's 125 over 78, SATs are 100, afebrile, urine output's pretty good. They have some nausea, no vomiting. They have incisional abdominal pain. What sort of thoughts? This is an early patient, gastric sleeve. What sort of thoughts might we have about this patient, or what's abnormal? Sorry, what were you saying? He does look pretty good, but has a lot of nausea. Can't take any fluid down at all. Yeah, so that can be pretty normal. In the first 24 to 48 hours, you may have nausea that just doesn't improve. They can try antiemetics. They try to drink something and they have worsening nausea. They may feel pretty bad about it, but in this situation where everything else looks okay, you can reassure them that that swelling that happens from stapling along the stomach and having a bougie in there is going to improve over about the first 48 hours. It can be very uncomfortable and a little concerning for the patient, but you really see dramatic improvement at the 48-hour mark. So, of course, continue volume resuscitation, antiemetics, and then just encourage them to do the best they can in terms of oral intake. Patients who have this scenario are going to be in the hospital for probably a day longer than the 2-night expected time. Okay. Now, scenario number 4. This is a patient who is status post-gastric bypass. Let's say they are a year out from the gastric bypass. They come into the hospital with increasing and severe abdominal pain, nausea, and then they start producing bilious emesis. Notice that I don't have any labs or vitals listed, but what sort of thoughts do you have about this patient? So let's look at the anatomy very closely first. This is the gastric pouch. So when you eat, food comes in the gastric pouch, goes down the roux limb. This is the bypass limb of jejunum that we brought up. It only is optimally absorbed once it reaches this jejunal anastomosis, where it mixes with the biliary secretions from the liver, pancreas, gallbladder. Now, if you have bilious obstruction, what is that? Bilious emesis, sorry. What does that tell you? It tells you that bile, which is in this area and comes out through here, is somehow making it all the way back up there. So what sort of, what ways could this be possible? Exactly. So bowel obstruction somewhere along this pathway, usually in the what's called common channel, which is after the jejunal anastomosis. And this represents a closed loop obstruction because let's say you had normal anatomy. We'll just look at this area. Your stomach was draining directly to the small bowel. If you have a bowel obstruction here, you can vomit to relieve the obstruction, or an NG tube can go down to relieve obstruction. But if you have some sort of blockage here, you have fluid backup potentially into the stomach, into the remnant stomach, which can become distended because it has no release valve, no way to relieve the obstruction. There are many ways to have bowel obstruction as well without bilious emesis too. So it's not a needed criteria, but it's one that you can see. There's many ways this can happen. Adhesions is a possibility. Port site hernia is a possibility, especially early. Stenosis at any of these connections is a possibility. Internal hernia is a possibility. Volvulus is a possibility as well. Again, these patients, fluid resuscitation and operative intervention. And that's even without imaging, vitals, labs telling you anything's wrong. If they're having bilious vomiting, you know that you have a problem. Bowel obstruction, maybe closed loop obstruction that you need to deal with. Okay, so scenario number 5. When patient status post gastric bypass, let's say they're also a year out from the gastric bypass. They have sudden onset abdominal pain, nausea, distension, but no vomiting. They're hemodynamically stable. White blood cell count is just a little bit above normal. Lactate is 3.1. The CT that's obtained shows this. And hopefully you can see well enough, but there are some swirls here in the mesentery as well. So what do we think this is? It should be, I think I mentioned this a little bit in the last one. What sort of things do we think this might be? Sorry? So you're saying mesenteric artery syndrome. That's a good guess. That's a possibility. This CT, I'm not sure if you can see it all that well, but these are slices showing swirling of the mesentery. Any other thoughts? So swirling of the mesentery is typically a characteristic of internal hernia. Internal hernias are caused when bowel slips through the connections we make. As you bypass the limbs and bring up a jejunal limb, you can get bowel slipping underneath the mesentery of the roux limb. You can also have bowel slipping between the mesentery of the colon and the roux limb. And you'll typically see a twist, but not always. You may also see the anastomosis displaced from its usual position in the left abdomen to the right abdomen, but not always. So again, you have to follow the same rules as bowel obstruction in a gastric bypass patient. They should go to the operating room pretty quickly because there's the possibility of a closed loop obstruction if you have a bowel obstruction. Sometimes you're going to see these findings, sometimes you won't. They should have reduction of the hernia if there is one, and closure of the defects, Peterson's defects, or the defect between the jejunal anastomosis. Okay. Number 6. So patient transferred from an outside hospital with abdominal pain and free air. They had been admitted to the outside hospital for pneumonia, and it had been improving pretty steadily with treatment. For some reason, they had vomiting or nausea, and an NG tube was placed, or a new one replaced the prior NG tube. Looking back in the notes, you can see that NG tube placement was pretty difficult. And in this patient, bypass was 9 years prior. It doesn't really matter exactly how long ago it was. That's just this is a particular case that I know of. So this is exactly how long ago it was. Now the CT they arrived with show specks of free air near the gastrojejunal anastomosis right here, and some free air in the upper abdomen as well. The prior CT imaging when the patient was in the hospital for their pneumonia didn't show any free air at all. So what thoughts do we have? This is a little more complicated one. So what's wrong? Obviously the free air is wrong. Perforation, yeah. And what are the reasons for perforation in any general surgery patient or gastric bypass patient? NG tube placement is a reason for perforation. Also, reasons for perforations are marginal ulcers, just like any other marginal ulcers, or duodenal ulcers, just like any other general surgery patient can have. Bowel obstruction leading to perforation is another reason that any general surgery patient or gastric bypass patient can have as well. So this is a particular case that I know of and I took care of when they arrived at my hospital from an outside hospital. This was when I was in Pittsburgh. This is not a picture from that in particular, but it's just a representative picture. This patient had what I think was perforation of the gastric pouch from an NG tube placement. They suddenly worsened after the NG tube was placed. They had imaging beforehand that was fine from the abdominal perspective, and after the NG tube placement, they had free air. For this patient, we laparoscopically washed out the exudate and peritoneal contamination from the perforation, and then closed the perforation with a Graham patch. A Graham patch is when you bring up a loop of omentum to cover the perforated area. Your omentum in old surgical lore is known as the policeman of the abdomen. It often covers whatever's perforated. If you have appendicitis, it can cover that. If you have severe cholecystitis, it can cover your gallbladder and wall it off from the rest of your abdomen, potentially saving your life. So we can use it for that property as well to close whatever hole we want to close. Just place omentum over top and then suture it down, and that will heal over a period of time. So this scenario is to highlight the fact that unless you have a lot of experience with placing NG tubes, you really shouldn't in gastric bypass patients. And having experience means understanding how large the pouch is, how far down it is, what sort of resistance you should feel as you place the NG tube. Now, a related case to this, marginal ulcer and marginal ulcer perforations. So we mentioned marginal ulcers, but a description of marginal ulcers is an ulcer that forms on the jejunal side of the gastrojejunal anastomosis. This is a view looking down an upper endoscopy, and these are the marginal ulcerations. This is a suture from the staple line. This is all the way in the distance, the jejunal root limb. People who have marginal ulcers can have terrible epigastric pain. They can come to the hospital on a weekly or daily basis and go through the emergency department. There's a risk of perforation as the marginal ulcers increase in size, or you might say get thinner, eat more and more into the bowel wall. The main cause is smoking. If a patient smokes, it's only a matter of time until they get a marginal ulceration. If they have a marginal ulceration and they don't stop smoking, it's never going to heal no matter what you do. That whether you use medications like Carafate and proton pump inhibitors, or you revise them, if they continue to smoke, they're not going to heal and they're going to ultimately perforate. So that's why I don't do gastric bypass in any patient who cannot quit smoking. NSAIDs can also cause marginal ulcerations, although I don't think as frequently as smoking. H. pylori can cause marginal ulcerations. This is probably the best marginal ulceration to have because this can be treated. Gastrofistula, meaning a connection between, I'll go back over here and show you, a fistula between the large stomach and the small pouch can bring acid from the large stomach into the pouch and cause a marginal ulceration. The reason marginal ulcerations are on the jejunal side is because that jejunum is not used to seeing the acid secretion from the stomach. This is an abnormal connection we're making, and the mucosa of the jejunum doesn't have the protective mechanisms that the stomach and duodenum do to prevent ulcerations. So again, treat with PPI, Carafate, and you must stop the causative agent, whether it's smoking, NSAIDs, H. pylori, GG fistula. Okay, number 7. So this is a patient, let's say they're a gastric bypass patient the night of postoperative day 1. Heart rate is 120, blood pressure is 115 to 45, SATs are 87. EKG is done, and they have a S1, Q3, T3 pattern. There's chest pain with inspiration, pleuritic chest pain. There's no abdominal pain. From the abdominal aspect, they're doing pretty well. No nausea, no vomiting. What are our thoughts for this one? Right. So I put this here, but also recognize that most patients with PEs don't have this finding. The most common finding is tachycardia. Okay, so yes, postoperative pulmonary embolism. This classical finding is seen when you have an increased volume and pressure within the right ventricle. It's a measure of this finding is a measure of right ventricular strain. Now, interestingly, bariatric patients have some of the lowest rates of PE and DVT compared to most other surgical patients, especially trauma or oncology patients. Does everyone have any thoughts why that might be? It's actually on the screen and partially, but for the risk factors for DVT are venous stasis, vascular trauma, or malignancy. The bariatric patients don't have any malignancies because we screen them for that. They don't have any recent traumas. They are getting up and moving all the time with help of the nurses. So their risk profile is a lot lower. Furthermore, all bariatric surgeons pretty consistently use DVT prophylactic in their patients. And as we all know, that's not the case for every other type of surgical patient. Some trauma patients have contraindications for DVD prophylactic, for chemical DVD prophylactic as well. Some patients with a head bleed, even a few days out, people are hesitant to use DVD prophylactic, and reasonably so. Okay, so clinical scenario 8. This is a patient who's 5-day status post gastric bypass. He was discharged home on postoperative day 2 as expected, had an uneventful hospital stay, history of obstructive sleep apnea. However, he forgot his CPAP machine at the hospital. This is not so much of a scenario as a kind of like a warning, because this is an actual patient, and this patient had a hypoxic respiratory arrest and death due to poor compliance with the CPAP machine, not using it at home because they lost it somewhere, didn't bring it with them. And this patient, from this information was abstracted from this publication. They ruled out other causes, and they concluded there was a hypoxic arrest during sleep. This can happen in the hospital as well if patients don't use their CPAP machine when they're sleeping or even just taking a nap. So that's why must, in capital letters, they must use their CPAP in the hospital and home until their obstructive sleep apnea results, which is around 50 to 70 pounds of weight loss. Okay, and then, there's some other things that can come up with bariatrics patients, also any general surgery patients, wound infection, of course. You'll see redness, swelling, pain, elevated white count near the incision, port site hernias causing bowel obstructions. If you carefully palpate the incisions, you may be able to feel a lump of small bowel in the port site. They're going to have obstructive symptoms as well. Abdominal compartment syndrome. This can happen with any general surgery patient, can happen with trauma patients, can happen with patients who are aggressively fluid resuscitated after pancreatitis. You're going to see decreased renal function. If they're a ventilated patient, you're going to see increasing peak pressures. You can use a bladder pressure monitor to diagnose it, but it is a clinical diagnosis. Rhabdomyolysis. If a bariatric patient is on the table for several hours, say a difficult revisional case, and they weigh 400 pounds, that's 400 pounds of weight on their legs, continuously for that period of time. Patients have developed rhabdomyolysis. You can diagnose this with urinary testing as well. Fluid resuscitation is the main treatment. Some people say alkalization of the urine is appropriate. Some say that's not appropriate. And then refeeding syndrome after prolonged hospitalization. Again, with any general surgery patient or bariatric patient, after a surgery or a trauma or prolonged ileus, they're going to have decreased oral intake. If these patients were to start eating or drinking, and you can drink a lot of calories, a milkshake from a fast food store has 1,200 calories potentially, a large milkshake. If they start taking in a full complement of calories after a prolonged period of fasting, they can have a metabolic response where they move electrolytes, in particular phosphorus, into their cells before ATP. However, that is going to affect cardiac function and other function as well. You can have MIs and significantly low phosphorus, magnesium from refeeding syndrome. So, good. So now, just to close us out here, a few studies on the benefits of bariatric surgery. There have been a few large cohort studies. This one looked at 2,500 patients. This one looked at 7,900 patients. These are retrospective studies, of course. They matched obese patients with who had bariatric surgery with obese patients who did not have bariatric surgery. They followed these patients for up to 14 years, and they found a significantly lower mortality even as early as 1 to 5 years after bariatric surgery. The hazard ratio is 0.45, meaning the risk of death was less than half for obese patients who had bariatric surgery compared to obese patients who did not have bariatric surgery. And this finding continued out 5 to 14 years as far as they studied it. Now, I believe bariatric surgery reduces mortality. This is a retrospective cohort study, so you can't precisely say that. But this is the data that we have at this time. A similar study found that there was a reduction in death from cancers of 61%. These are mostly gynecological cancers and some colon cancers as well. There are many other studies that show similar findings as well. Bariatric surgery can reduce comorbidities like diabetes by 60–80%, and this means that 60–80% of these patients will potentially no longer need their diabetes medications or have a much lower need for diabetes medications. Similarly, high blood pressure, sleep apnea, no longer needing your CPAP machine, polycystic ovary syndrome, meaning fertility, regular fertility. If you're interested in reading more about these values are changing all the time, so that's why the ranges are so large. But if you're interested in seeing some of the most up-to-date information, the ASMBS website has a lot of the studies listed. All right, so summary from nursing's perspective, nursing care is critical to the success of any program. Nursing activities can facilitate pain control, food intake, ambulation, and identify deviations from typical patient course, which potentially could represent complications. So again, thank you everyone for your time. I appreciate being asked to talk to you today. Are there any questions at all? Okay, that's a good question. It's not very common, and if you're asking how frequently I see it, almost never, because for bariatric patients, we check their vitamin levels on a regular basis and replace them as necessary. The patients who are returning to us and are compliant are taking their vitamin B medication. I think those patients who don't seek appropriate follow-up care, they can have low B12 levels. Interestingly enough, it's very easy to get B12 even for vegetarians. Many studies have shown vegetarians don't have low B12 levels despite not eating meat products, because any grain you have has little bits of insects or animal products inside it, and you can get enough B12 just from that. So the gastric bypass patients who have bypassed their, who have excluded their gastric remnant can have some problems with absorbing B12 because of lack of intrinsic factor, but just a small supplement for someone who's adequately compliant will reduce that from happening. Good. Thank you. That's a good question. Sure. So, let's see. Excuse me. Let's see what I called number listed here. Yeah. So we're going to be running the lidocaine infusion at 0.5 to 1 milligrams per kilogram ideal body weight per hour, and this is going to go from the beginning of surgery to the day after surgery ends. They're going to leave the OR with a bag of lidocaine hanging, depending on the size of the bags we have available, because there are some shortages, but ideally they would leave with a bag of lidocaine hanging, and then that would run continuously until it ends about 24 hours later. There are several studies that show decreased opioid usage with patients who are getting lidocaine infusion, improved pain control, decreased ileus, decreased nausea, potentially from the decreased opioids that the opioids they're not having. So, and there's a push for bariatric programs to use ERAS protocol, and this is one aspect of that.
Is the lidocaine infusion used for pain management and other surgeries at this point, or is it mostly in the bariatric surgery patient?
No, some colorectal programs are doing it as well, and some OB-GYN as well. But it's mostly programs and hospitals that want to do an enhanced recovery program. This is one of the many components that you can do.
We appreciate you coming tonight. This presentation is awarded one contact hour through the American Association of Critical Care Nurses. So if you want a CEU certificate, I need you to fill out the evaluation form and hand it in to me. We'd like to thank Dr. Andrew for his time. He has no conflict of interest. I have to make that announcement for this talk as well. For those who are members or even anybody who's thinking about wanting to be a member of our organization, you're welcome to stay for our short meeting that we'll have after the presentation.